Good morning, everyone. Welcome to another episode of Ben's Den. Today, I'm very excited to have a very, very special guest, Henish Bhansali, who is on the board of NACOS. And just this morning, I got to learn that he's also in a very elite group of people in the country who is a presidential leadership scholar. I didn't know that about Henish, so that was a great thing to learn this morning. And is also the chief medical officer for Medical Home Network, a very focused care delivery network that's focused on safety net communities. But I'm going to have Henish introduce himself a little bit. He can probably do a better job than I am. Henish, please, if you can introduce yourself to our audience.
No, thank you so much for having me on the show. It's a pleasure to be here, and thanks so much for that introduction. I don't think there's much more to it than that. But as you shared, I serve as the chief medical officer for Medical Home Network. I'm a primary care doctor by training, internist, and I've spent most of my life caring for patients in low-income settings in underserved communities. And it is a privilege to both be at MHN and thrilled to be on your show.
And one of the things that I read in your profile, which caught my attention, which is how you talk about your parents giving you the opportunities that you, in turn, intend to enable for the next generation. That's something that I personally am passionate about. I think we all talk about the things that we need to do in healthcare. But for me, sustainability, points to, are we enabling a system for the next generation, right? I mean, are we doing right by the next generation of consumers who are going to be dealing with very different realities in the world, right? What kind of healthcare experience are they going to have? So if you could quickly talk about why that speaks to you, why that's important to you, I would really appreciate that.
Yeah, share. So I'm the son of immigrants, came here when I was about 10 with my parents. And maybe a little bit of history is that my parents, being immigrants, had navigated the Medicaid system for a short period of time. And then my mom was diagnosed with chronic kidney disease, and over a decade and a half, navigated the commercial and the Medicare system for a while. So when we're thinking about a very personal story of having to navigate healthcare as immigrants or as those that are not as familiar with the healthcare system, I mean, I consider us very privileged to have the care that was delivered to us, but the complexity of that care delivery, just navigating the system was very hard for immigrants. And I can imagine those I mean, it's hard to navigate for pretty much anyone, right? Even my friends who are well educated and well informed about the healthcare system still reach out to me to help them navigate it. So I think we have a complex healthcare system that in many ways we're privileged to have. And part of the reason the complexity exists is because we're trying to do a lot for our population. But the flip side of that is that it is a complex system to navigate.
And it's really good to hear that, Manish. Honestly, my foray into healthcare entrepreneurship was also born out of a personal experience. We've all been victims of the disjointed process, right? So I spent an entire night on a Sunday in the ER, and the next morning I decided to be an entrepreneur. So that's kind of like how my journey began as well. So we all have a personal story attached to it. And I think that's what makes this really such a beautiful experience, that it's not driven by a very altruistic intent, right? So with that, let's dig into the topic for the day, Henish. It's something that I'm very excited about. I know you've done years of work in this space, and it's a real change that we're witnessing in front of our eyes, which is the changing dynamics and the relationship between payers and providers and other partnerships that are enabling that change, right? So thinking about that as from a value-based care point of view, and say, okay, there is an evolving value chain, right? VBC is forcing all the constituents and stakeholders to relook at the dynamics, reimagine the ecosystem. What have you seen in your experience with MHN in the journey to VBC? What are we getting right? And what do you think we can do better so we can scale VBC and maximize its potential?
So it's a broad question, and maybe I'll take it one piece at a time.
Sure.
And maybe I'll share to sort of set the stage what my journey has been. So starting in residency shortly thereafter, I worked at an academic center and saw how care was delivered there. Then at a academic community-based hospital system, then at Oak Street, then at Dooley Multi-Specialty Group, and now at MHN as someone who enables and partners with federally qualified health centers. Let's start with what payers and providers get right about BBC and where there's still some daylight. So for providers, they've been delivering value for their entire, career, right? That is what they do. So what does value-based care mean to them? That's the first question. When we say, hey, well, let's start delivering high value care by value-based care, they're like, well, that's what we've been doing, right? Most of the people that they're delivering high value care within the construct of what is available to them. And that's probably a pretty big asterisk, right? Is that value isn't necessarily delivered only in VBC arrangements. There's high value care that has existed prior to risk-based arrangements, but as the reimbursement for unit-based care decreased and the compensation for that was the volume increased, the quality of the care that was delivered was impacted, right? Because now you have to increase your volume just to maintain your level of compensation. And by definition, you have less time with patients, fewer resources for a given patient. And if you take a look at the data over the last couple of decades, you can see that the number of patient-facing FTEs, whether it be medical assistants, nurses, physicians, APPs, et cetera, has actually gone down at a per capita level. Whereas the number of people, so administrators, et cetera, within healthcare has actually gone
Up. Yeah. Yeah.
and then for payers, the question is often about incentives, right? How can we construct a reimbursement model which will allow for the highest value activities, but as determined by the payers? They may not necessarily align with what a provider feels is the highest value. And I could give examples of that if useful.
Now, do you see the patient being a factor to get these two principles on a common ground? For example, if the contract is constructed with the patient in mind, right? And you're absolutely right. I think the BBC has been a very proven model when it comes to the financial aspects of healthcare, right? But when you think about the actual patient's reality, whether it's access, affordability, consistency, whatever would be the realm of the consumer standpoint, there's still a lot of work to be done, right? Regardless of which community you look at. So would that be a way to come at this and say, hey, if you're thinking about metrics that can be redefined, so we can truly see or realize the potential of VBC and democratize the value of VBC, maybe start with the patient in mind, right? Is that something that you see happening, or do you believe that's something that we can enable?
So I think there are some places where I see that happening and others where it's still gaps. Let's talk about where that is happening. It's keeping the patient in mind. The sort of the 10,000 foot view is keeping people healthy, happy, and out of the hospital.
Yeah. Right.
And how do we do proactive care, preventative care, et cetera, to allow for something like that to happen? So for a metric and this is a metric I've used across multiple different organizations that I've been at, is admissions per thousand. How do we keep people out of acute care when possible? This is very well aligned for the patient and the PCP and a payer. It's not necessarily aligned for a hospital system who needs to, depending on the hospital system, who needs to keep their beds full, because any empty bed is a unit cost to them. And so there's some misalignment, but for a large portion of it, admissions per thousand is a great metric that everyone can get behind, right?
100%.
So, and one of the models that's done a really good job around that is the REACH model from CMS, right? If you take a look at the quality metrics, there's 3 equality metrics that are all focused on utilization. It's admissions or unplanned admissions, readmissions, and timely follow-up. Now, timely follow-up is a process metric that really is focused on impacting those 2 outcomes, but that aligns. There are a lot of things that don't necessarily align though, right? If there's going to be an impact on a patient, that's going to take 5 years or 10 years for it to garner value, that the investment from the payer may not be as applicable or as prioritized. Prioritized is the right word, not applicable, right? As prioritized, because if they make that investment in the patient today, but if it's going to be 5 to 10 years for that to actually come to fruition or have a meaningful ROI, then that patient may or may not be with them. Who knows what happens? But from the provider lens, that's not the case, right? Providers, especially primary care providers, are expected to have patients for a majority of their life, ideally, right? If the patient has a good primary care provider relationship or whatnot. So managing conditions that are priorities to the patient that may help in longitudinal care but not necessarily acute management, there can be some misalignment there.
Got it, got it. And in this transformation, one of the things that obviously is something that's very near and dear to us just by our identity is tech and data, right? For us, the way we look at it is if you look at traditional fee-for-service models, cash is king. Everything is about cash flow, services, volume, right? In value-based care, at least from my perspective, data becomes king because you're taking data as your leading indicator of performance and outcomes. And the platform that you use to scale access becomes your kingdom, right? That's kind of like how we rationalize with that. What is from where you are, from your vantage point, what's your point of view on the role that tech and data play in enabling or democratizing value-based care?
Yeah. So one example I often give is for Pearl Health. Pearl as a tech enabler is probably one of the stronger entities out there, or if not the best entity out there when it comes to taking true data and helping the end user have the next best action. And so data and tech enabling at the point of care the next best action for the next best patient, that really allows for, to your point, that democratization of the data and enabling that. However, there's still a couple of caveats to it. What do we mean when we say the word best? Best in what sense? Is it best for contract performance? Is it best for clinician efficiency? Is it best for patient outcomes, right?
Right.
And so I think that there still continues to be gaps in figuring out what the next best action is for the next best patient, if it's necessarily in the patient's best interest, in the care delivery entity's best interest, or the provider, payer, or payer organization's best interest, and or some combination thereof.
So in that way, I just want to
Yeah,
just
double click.
hyper a little bit.
Yeah.
So the next best action for the next best stakeholder in the care continuum process, how do you see AI being a factor? Because the premise of AI is that it can help us analyze and predict better than we've ever done before, regardless of which industry. And in many ways, you're ushering a new era of reindustrialization of multiple sectors, right? I mean, you're talking about retail, you're talking about financial, you're talking about healthcare and whatnot. In fact, I was pleased to read that adoption of AI, healthcare is the second largest compared to all progressive industries, right? So that's a good sign that there is an awareness, there is an attempt, there is a piloting of these technologies happening. Do you see that as being a factor for identifying that next best action for the next best stakeholder in the care continuum process?
I think to your point, it really depends on how you structure the AI and what you're using agentic AI and whatnot for, right? So one of the things MHN has launched is doing health risk assessments for people because we work with a patient population that has a high prevalence of social and behavioral disturbance of health. And so doing these screenings is critically important. And as we have launched this, I mean, what we're able to do is really get from or better understand our population. And we've been using agentic AI to better understand our population and their needs. We're not there where we can define what the next best action is, but it really helps us get a lot more insight, a lot more quickly and more quickly so that we can manage our patients better. And I think that this becomes the standard of care. And there are a couple of different ways that this is going to become the standard of care, right? So there's another entity out there. I think they either are going to launch or recently launched, and it's Get Healthy. And this is a direct-to-patient chat GPT type. It's an LLM that engages with the patient on their health and a variety of things, and is able to then aggregate that information for the person at the point of care. The issue really becomes from a PCP's perspective, and it's probably one of the better perspectives I can speak to, is that you don't have all of your patients in any one model or using any one tool. Right. So getting these disparate insights about patients that are not aggregated. But I do think that, to your point, that's where we're going.
Right.
Is that I can see a future where you have a single type of an agent that is deployed to aggregate multiple different types of information for patients, either directly by the care delivery entity or a B2C model. And then this information, once aggregated, can be provided to the point of care to much better inform next best action. The delta will still exist in what that next best action is for whose benefit. Is it for the patient's benefit, care delivery entity's benefit, and so.
Right. And one of the things that, I think the whole world is quickly realizing with AI is, and it's been our experience and our posture on this as well, is that, especially in healthcare, we believe that healthcare will always remain human-centric, finish, right? I mean, you can look at, but I think the quality of the system is going to be very dependent on decisions and actions that humans control, right? At least for the foreseeable future. But the efficiency of the system, which is scale, which is throughput, which is enablement, right? Your speed to get to that decision or action will be heavily impacted by how you apply AI, right? So we are very grounded. We have 3 agents in the mix in our platform, and we're very realistic about how we are coming at this. We are not carried away by the hype of a GPT-5 model or whatever be the case. We are fundamentally looking at this as saying, how does it make that core platform experience better and more scalable without disrupting the human component of it? That's at least our approach, and that's been our learning, that quality is still being controlled by human decisions and activities, but the scaling and the efficiency of that workflow is directly being impacted by how you apply AI. That's been our approach with it, right?
Yeah.
Good.
Yeah, and I think that's right. And maybe to give an example around the first piece is how are we actually controlling the quality? So a lot of PCPs have recently started using a platform called Open Evidence,
Open evidence, yeah, you have.
right?
Yep.
And Open Evidence is, I believe it's an LLM that aggregates and integrates a ton of different research and clinical information. It's partnered with JAMA, et cetera. And this can be a tool that is ubiquitous across the patient population, see as a strong clinical decision support tool, right? Now, what this is not focused on a specific contract or a payer, et cetera. This is for any patient that's coming in. If you're able to feed it the right information, then it can help you make much stronger clinical decisions. Now, this is ubiquitous, patient-centric, clinical evidence-based. So that is those are the types of tools that we would want to develop, but from a pop health perspective.
100%. And on the same token, if you think about the next 5 years, right? Because there's always this excitement about, we tend to overestimate the long-term future, but underestimate the short-term future with any technology. But, if you look at 2030 and say, okay, there is this real movement around industrial variables that are progressing more towards value-driven care, however we define it. And then there is this horizontal force around technology, data, and AI that is, it's almost like the tipping point of this transformation. You see a world in 2030 where payers and providers are operating as one cohesive unit. And by that, I don't mean as one corporate entity or, under one number, in a very shared infrastructure, which is, for example, let's take the model, right? Let's say open evidence is the model that allows for decision-making for both payers and providers, and they share that intelligence amongst themselves, right? Or the fact that you can have a predictive, preventive network ecosystem, especially when it comes to non-mainstream services. And we know food is a huge factor, social determinants are a huge factor, genetics is a huge factor, right? Do you see a future where AI brings these controls closer, assuming that there is the right level of accuracy and efficacy to that data, right? Do you see that happening in the short term? Is that something that you feel positive, or is it way too early for us to take any kind of assumption or posture on it?
So I think the ability to do so will be available in the next few years, right? I don't think the availability of the tech or whatnot is going to be the limiting factor. I believe the limiting factor is really going to be multi-payer alignment. It's a clear example can be even within a specific payer class and a payer, there's still discrepancies, right? So let's take a look at Medicare and let's take a look at CMS Medicare programs. And let's take a look at two of their biggest ones, MSSP and REACH.
Yeah.
What quality means for MSSP is meaningfully different from what quality is within REACH, right? So the metrics are different. Well, now you have a patient that's coming to you. If they're an MSSP, then there's going to be regardless of whatever that tech-enabled ecosystem is, what to do for that patient is going to differ versus that exact same patient is in REACH, right? And this is for a single type of patient within this is not even Medicare Advantage, which has a whole different slew, and then that is contingent on the payer. So, but this is incredibly disparate from, again, going back to that clinician perspective, is that if a patient is an MSSP versus REACH versus Medicare Advantage, it is the same Medicare patient, but I will need to manage them differently because each one of them has different quality measures, each one of them different resources, right? Because Advantage offers the plan benefit design, et cetera. And so quite a few other benefits that the patient can engage with. That is what I believe is really going to be the limiting factor. If we want to create this payer provider tech enabled optimization system that would allow for, the synchronized care for a patient, that payer alignment is table stakes for that to happen. Because until that doesn't happen, different payers and products will want different things for the provider to deliver.
No, you're absolutely right. I was recently had an opportunity to talk to multiple BCBS organizations among multiple states, and you quickly realize is that they don't even speak the same language. It's really it's alarming, in some sense, but you also understand that it's a byproduct of the system, right? That's another way to look at it. But you're absolutely right. Unless there is an alignment and standardization of some level of the metrics, I think there's only so much that technology and AI, right? So you're absolutely right. So,
We're seeing
great.
one comment around this. We are seeing some movement in that, right? Like if we take a look at Epic, for example, you have Epic integrating clinical decision support. There's the Epic Payer platform that is bringing in quite a bit of data from the payers. Epic has the Care Everywhere feature where care is delivered for the patients. Epic is now connected to QHINs, so it is also bringing in that insight, and it is trying to create this single ecosystem where a PCP can manage a patient and to make it easier for the PCP to figure out what the next best action is for a patient. But we're getting there, and I think and Epic is just one example, but there are other ecosystems that are showing this too. So we're getting there, but until that second piece that I mentioned earlier is solved, I think this evolution is going to plateau.
And we participate in QINs as well, Henish. And one of the things that we are quickly learning is that you're right. I think these networks are allowing for data. Let's just take data as an example, right? Data availability at a level that we've never seen before. But then what you quickly realize is the contextualization, the standardization, and the actionability of the data. There's a lot of devil in those details. So that's the grunt work now. That's the grind for us to, clean. That is better. It's a good problem to have, but it still is a problem. So that's basically where we are here. So with that, Henish, thank you so much for taking the time. And we wanted to keep this brief. Your time is very valuable. But, there's always this fun question that I ask at the end of the podcast. This is going to be the most challenging one. So we're talking about payers and providers, right? And the relationships they have. So let's just think about a fictional scenario where if the payers and providers are dating, they're in a relationship. Okay. So the question is, how long do you think that will last? And two, who's the first to ghost the other person? Who's the first to ghost out?
So I think, I'm South Asian, Indian by background, and the way my parents grew up is that when you're married, you're married forever because it's two families coming together, and there's just so much at stake,
Yeah.
or that relationship to not work. And so I think that payers and providers are in it for the long haul. I don't think there's anyone ghosting anyone anytime soon. But I think that the changes that are coming up and you and your team are working on, the agents, the AI, the better decisions, is going to make their relationship better where they'll start writing a few more cards to each other on Valentine's Day. So
I was just gonna say it would be a very long marriage, but it's just any marriage where neither one is happy, but they live with each other.
right.
Because of common interest. Henish, thank you so much for that. We really appreciate you taking the time to join me on this episode, and good luck with everything that you're doing. And I look forward to staying in touch. Thanks.
Thank you so much for having me. This has been a pleasure. Take care. I can be well. Bye-bye.
Thank you, Henish. Bye. If you enjoyed this episode, make sure you subscribe to our channels. Episodes will be posted once a month with a variety of industry leaders, and you can follow us on LinkedIn, Twitter, and Facebook as a Garajan. Have a good one.